Hello, welcome to my introduction to rheumatology talks. I've been a rheumatologist in practice for over 30 years, and during that time I've had the opportunity to give lectures to sophomore medical students in their Introduction to Medicine course on rheumatology. That's the basis for the lectures that I'm going to give. I've tried to avoid using jargon as much as possible when I made these, but occasionally I may use a word that I don't explain well. If I do, just feel free to look it up. The word could be typed into Google and you can generally find the meaning of it. The lectures will be posted in the order in which I made them, although many times they'll stand by themselves, so one doesn't necessarily need to watch all of them, and certainly you can pick and choose which talks might be of interest to you. I hope this is helpful to you and informative, and I hope that you learn something. Thank you for listening to my talks.
Hello and good afternoon. Today we are going to discuss fibromyalgia in our continuing discussion of Introduction to Rheumatology. So the first question that one has to ask is, what is fibromyalgia? And this is somewhat confusing to many. Basically, it's a syndrome of widespread pain that's associated with fatigue and a sleep disorder. It doesn't really affect the bones, joints, or muscles, although they can be very painful. It's not really an arthritis, although rheumatologists are often involved in the diagnosis and management because we are the ones that do the arthritis or the joint exams the best. It's not immune mediated like the other diseases we discussed, and there's not any pathology of the joint. It's felt to be neurochemically mediated in the central nervous system. And the neurochemicals are the chemicals or substances the brain uses to communicate with different neurons of the brain use to communicate with each other. And one of the challenges of fibromyalgia is that it is very chronic and difficult to treat. Now, the question is, what causes fibromyalgia, or what's the cause? And the cause is not really known, but it's like many conditions. There's a genetic predisposition and then something in the environment kicks it off, an environment or trigger. The triggers generally fall under the classification of stressors, and a good example of this is the epidemic of the Gulf War syndrome, which was reported after the first Gulf War, where up to 45% of the deployed troops that returned home from the Persian Gulf had a constellation of symptoms of muscle and joint pain, headaches, fatigue, memory problems, and GI problems that look very similar to fibromyalgia. There's not any really pathologic anatomy associated. There, again, is not any abnormalities of the bones, the joints, or the muscle. The muscle has been considered the primary source of abnormality in many years past, but studies have been done and not really shown that this is true. A lot of times there are some problems with the muscles in patients associated with this, but that has more to do with being sedentary than with respect to actually disease of the muscles. What's the pathology of this? In order to understand that, I think one needs to understand how the brain gets information that it perceives as pain. This is what we call the peripheral afferent nerve fiber. It comes from the periphery. It sends signals to the spinal cord, and the first processing of data from the periphery occurs in the dorsal horn of the spinal cord. This is the front of the spinal cord. This is the back or the dorsum of the spinal cord. Where the nerve enters, there's an interaction between the peripheral afferent nerve. There's also information from descending spinal thalamic tracts that send information into the dorsal horn. And from that, sometimes there's signals sent back to the periphery that can release chemicals that can sort of excite more sensation back to the dorsal horn, and ultimately a signal makes its way up to the brain where the final processing of the information is done and pain is perceived. This is a schematic of the dorsal horn of the spinal cord, and we're going to talk about that more in a minute. There's a lot of data to suggest that there's a problem with the neurotransmitters that occur in here, and which is shown here. There are abnormalities of serotonin metabolism and transmission. The cerebral spinal fluid shows the norepinephrine to be lower. Serum serotonin levels are lower in fibromyalgia. Cerebral spinal substance P is actually elevated, and we'll talk a little bit about that. And that there appears to be neuroendocrine dysfunction. Growth hormone, somatostatin C is disrupted, and patients with fibromyalgia had a decreased hypothalamic production of ACTH and epinephrine in response to hypoglycemia. Now, in order to understand how these neurochemical abnormalities might be associated with pain in fibromyalgia, let us discuss the central pain pathways. Pain sensation is not just a one-directional process from the sensation to the brain. Rather, there's a complex interaction between the nerves coming from the site of pain and nerves from the brain going back to the site. And that's what's represented here in the schematic of the dorsal horn of the spinal cord. The pain information is transmitted to the dorsal horn, which is at the back side of the spine, and the initial information comes in through the peripheral afferent nerve. Wind-up then occurs in the dorsal horn. Wind-up means is that repetitive stimulation or repetitious stimulation of the pain fibers results in an exponential increase in the magnitude of the response of the neurons leaving the dorsal horn, and that's what's shown in the spinal thalamic tract here. And data to support that, the NMDA receptors or N-methyl D-aspartate receptors are activated, which cause a long-acting stimulus of the nerve leading to the dorsal horn. Substance P, substance P, and nerve growth factor enhance release of glutamate. Remember that substance P is increased in the cerebral spinal fluid of fibromyalgia patients, thus abnormal wind-up is felt to be part of the fibromyalgia syndrome. And then note also that the mu opioid receptor reduces glutamate and substance P release. Other descending spinal pathways. Okay, so we say substance P enhances NMDA wind-up. Stimulation of the mu opioid receptor reduces glucose and substance P, so that actually downregulates the pain. And then there's other descending pathways that downregulate the pain. Serotonin and norepinephrine play a major role in the descending pain modulation. This is important when we go to talk about how we might treat fibromyalgia. So we have factors that can increase the pain wind-up here, and we have factors which can decrease the stimulus that makes it to the brain, including the mu opioid, the serotonin norepinephrine receptors. Other descending pathways from the brain that can affect pain include the GABA receptor, and then 5-HT3 can affect pain. Now, in addition to the wind-up at the dorsal horn of the spinal cord, we also have the brain involved, and effects on the brain can affect one's perception and distress from the pain. Things such as stress and anxiety can increase pain perception, increase stress related to the pain. Depression can affect it. Past experiences with pain and psychological trauma can affect the response to pain, and as mentioned, previous pain experiences. So there's sort of a whole group of things that can affect pain, some increasing the perception of pain, some decreasing the perception of pain, but what the result is an early and prolonged wind-up here in the spinal cord, and as a result of previous pain experience and perception in the brain, there's an increased and prolonged pain experience in fibromyalgia. So what do we see when we encounter fibromyalgia? How do we make the diagnosis? The typical presentation of fibromyalgia is generally a woman, although not exclusively, somewhere in middle age, between the ages of 20 and 60, who presents with a chronic widespread pain and aching associated with fatigue and a sleep disorder. Typically, they have fitful sleep and sleep that's non-restorative. In other words, they go to bed and do not wake up rested. The classic triad is widespread pain, fatigue, and a sleep disorder. The widespread pain is typically reported as "I hurt all over." The pain is more of a burning pain in the muscle than in the joints, and indeed it may feel like the onset of a cold. Fatigue is a big problem, and oftentimes there's an overlap with chronic fatigue syndrome, and when we talk about a lot of the things that can overlap with fibromyalgia, chronic fatigue syndrome is one of them. This is a very frustrating aspect of the syndrome. Indeed, many patients will continue to have problems with fatigue even after they're able to achieve improvement and live with the other aspects of the condition. The last part of this is a sleep disorder. Typically, it's non-restorative. A typical statement is, "I went to bed and slept all night, but awake and feeling more tired than when I went to bed." The spouse may note that there's a lot of restlessness and thrashing about in bed. In one of the early and classic studies by Mendelsky, what he found is that patients with fibromyalgia tend to lack stage 3 and stage 4 sleep. And this is just an example of a sleep EEG. An EEG is sort of a brainwave test, and a normal EEG, there's a lot of small, rapid waves. As one goes to sleep, the waves become less frequent. The frequency decreases, but the amplitude of the wave increases until we have in stage 4 and stage 3 and stage 4 sleep very large, slow brain waves. In REM sleep, it almost reverts to an awake-like appearance of rapid, small amplitude, high frequency waves. What Mendelsky noted was that there tends to be less stage 4 or restful sleep associated with this condition. There can be a lot of other associated problems with fibromyalgia, including migraine headaches, temporomandibular joint problems, depression, irritable bowel syndrome, multiple chemical sensitivity. And several years ago, there was a discussion that fibromyalgia may represent what we call a hypervigilant syndrome. In other words, patients with this condition are more vigilant. They could be more vigilant to chemicals in the environment. They may be more vigilant to body sensations than people that don't have fibromyalgia. Sometimes cognitive problems are reported and problems with short-term memory, what patients will frequently refer to as fibro fog. There can be pelvic pain. They can have chest pain that's not cardiac. They can have numbness, and it's non-dermatomal. And what that means is it really doesn't fit any known nerve pathways. So there's probably not an anatomic cause of the numbness or paresthesia. It's just sort of weird numbness and funny feelings that don't fit any known nerve pathways. They can have sicca or dry mouth problems. They can have problems with vasomotor rhinitis or runny nose not associated with colds or allergies. They can have trouble with balance or vestibular problems. There can be problems with swallowing. There can be problems with menses or dysmenorrhea or a lot of pain with menses, and interstitial cystitis has been reported. What do we find on physical examination associated with this? Number one, there is not any abnormalities of the bones, joints, or muscles. Everything works okay. And to the extent the rheumatologist has something to add in the workup and diagnosis of this, the rheumatologist does not find any abnormalities of the joints, bones, or muscles. However, there is tenderness in a very characteristic distribution, and this is a classic picture in fibromyalgia. Indeed, if you look at any fibromyalgia, one will find this, where patients will have many of these tender points, and not all of them, and these are not exclusive. In other words, they can have pain in other locations, but the classic locations are the occiput or the back of the head, the trapezius, along the medial scapular border, the supraspinatus, along the lower back or iliac crest, the gluteal areas, over the greater trochanter. A lot of times there's tenderness anteriorly in the muscles of the neck. There can be costochondral tenderness, lateral epicondyle tenderness, and tenderness in the medial fat pad of the knees. So these are classic locations. Areas that I also frequently find pain is the anterior shoulder bilaterally. And interesting, the tibialis posterior, the medial tendon of the ankle. Now, in order to classify fibromyalgia, and again, I'm using the word classification and not diagnosis, this is the 1990 classification criteria of the American College of Rheumatology, and actually I find that it's the most easy to apply. Basically, they're looking for widespread pain associated with fatigue and a sleep disorder. And we looked at the 18 tender spots. If patients had tenderness of 11 of the 18 spots, they were classified as having fibromyalgia. Now, in 2010, the American College of Rheumatology came up with a more, what I would consider more complex classification criteria. But again, this is useful in agreeing that all the patients in studies have fibromyalgia. And some caveats or differences between this and the old criteria of 1990. Number one, there's no physical examination involved. And so this would be helpful if one were trying to do a fibromyalgia study over the phone and doing questioning. You could ask patients these questions, determine if they would fit the classification of fibromyalgia, and proceed with the study. Therefore, in order to use the 2010 diagnostic classification or classification criteria, not diagnostic criteria for fibromyalgia, one needs to look at several things. Number one, the widespread pain index has to be greater than 7, and the symptom severity scale has to be greater than 5. That would count as classification for fibromyalgia. The widespread pain index includes many of the areas that we discussed when we were talking about the physical examination, only the patients will record these themselves, and if it's greater than 7, and if they have a symptom severity scale greater than or equal to 5, symptom severity scale includes fatigue, waking unrefreshed, and cognitive symptoms, and then they score those 0 from no problems all the way up to 3 for severe, pervasive, continuous life disturbing problems, and they give outlines. If with the whole widespread pain index, the system severity scale greater than 5, one can classify as fibromyalgia. Or if they do not have sufficient tender points and they have a whole body pain index of 3 to 6 with the symptoms with a somatic scale score of greater than 9. Okay, so they're using SS differently. SS here is symptom severity scale, SS here is somatic scale score, and the somatic symptoms are many. And this is just an example. These can include muscle pain, irritable bowel, fatigue, tiredness, thinking or remembering problems, muscle weakness, headache, pain and cramps in the abdomen, numbness and tingling, dizziness, insomnia, depression, constipation, pain in the upper abdomen, nausea, nervousness, chest pain, blurred vision, fever, diarrhea, dry mouth, itching, wheezing, Raynaud's phenomena, hives, ringing in the ears, vomiting, heartburn, oral ulcers, loss or change of taste, seizures, dry eyes, shortness of breath, loss of appetite, rash, sun sensitivity, hearing difficulty, easy bruising, hair loss, frequent urination, painful urination, bladder spasms. So if they have a lot of these somatic pain or a lot of these somatic symptoms, and remember somatic implies symptoms without findings, sort of like psychosomatic. If they have a lot of these, one could classify as fibromyalgia. Now, it is important that they do not have a disorder that would otherwise explain the pain. So this is the 2010 criteria. It is very useful, I think, in studies in order to have this classification criteria because you don't need to touch the patient. The trouble is in the office, it's more, to me, I think more useful to look for fatigue, sleep disorder, and the tender points of the 1990 scale. So in making the diagnosis, what other things do we need to think about? What other things do we need to look for to make sure that we're not missing something else? Basically, we're looking for any other conditions that can cause local achiness or fatigue. So the workup that I typically do, usually I'll do a complete blood count to exclude things like anemia and leukemia. I think anemia is overrated as a cause of fatigue. More often, when patients are anemic, they tend to have increased shortness of breath with exertion rather than fatigue. But I do look at a complete blood count. I also do a complete chemistry panel to look for signs of diabetes, liver disease, kidney disease, or electrolyte abnormalities. I mean, patients that do have failure of their liver or kidneys do feel poorly. And indeed, patients with hepatitis, viral infections of the liver can be very sick. I look at muscle enzymes. I look at the CPK muscle enzyme to see if there's clues of muscle breakdown. And remember that the AST or the SGOT are also muscle enzymes. I get a sedimentation rate to see if there's inflammation. And I get a thyroid test to see if there's clues of hypothyroidism. I find that what often happens with a patient presents to other physicians with this and no physical findings, that an anti-nuclear antibody or a rheumatoid factor will be checked. And as you can see from my list, I typically don't check these. Unfortunately, coming from other physicians, if they have an A and it's positive, they may be told they have lupus, which is sort of counterproductive to what we need to do, because then we have to explain why, even though they have an A and A, we do not find clues of a systemic autoimmune disease such as lupus. Typically, with my physical exam in the labs above or the labs listed here, I can see if there's clues that there is some sort of inflammatory process that may possibly be autoimmune going on before I order the ANA. The other problem we find is our diagnosis called chronic Lyme disease, and this was a problem more in the past where patients would present with this gamish of somatic symptoms, achiness, and fatigue, have a history of a positive Lyme antibody, or some physicians didn't even require the presence of a positive Lyme antibody, and they would classify this as chronic Lyme disease when the patient really had fibromyalgia. Now, how do I treat this? Number one, I think self-efficacy is key. In other words, patients need to have ownership of the disease. And so I think education is key. Basically, I tell them what we believe is the problem, and specifically I'm referring to the problems with wind up in the dorsal horn and how the brain perceives those problems. We also educate them that there is not a problem with the bones, joints, or muscles. They're just achy. I think it's the better the patient understands it, the better they will be able to cope with it. I have encouraged patients get a handbook of fibromyalgia, and I've listed the one that I've recommended most often here. Unfortunately, my belief is that this book is now out of print. However, patients have been able to find this as a used book on Amazon and things such as that. In approaching a patient with fibromyalgia, I think it's very important that the physician be aware of his own feelings regarding patients with this problem. One of the frustrating things about managing or treating fibromyalgia is that in spite of very careful and aggressive care, the patients many times don't have improvement, and there's a tendency, I think, among physicians to blame the patients. I don't think that's correct. And I think what's important is in approaching a patient with this, it's important for the physician to control their emotions. Now, one of the key treatments for fibromyalgia is cardiovascular exercise. I think this is very important. Indeed, in my opinion, it's probably the most important thing that a patient or someone can do to treat their fibromyalgia. Typically, I have patients start with just a few minutes of exercise a day. Oftentimes I find that if they do too much too quickly, they hurt more and quit. And so we want to start with an amount of exercise that they can tolerate and that they can do, and then they can build up. And so I may ask patients not to exercise in any more than 5 minutes a day to begin with. I ask them then to gradually build that up to 30 minutes, 3 to 4 days a week, in order to start to achieve some response. Now, a lot of times I'll have patients tell me, oh, they're doing stuff all the time, they're active all the time, is an excuse not to exercise, in which case I ask them to learn how to take their pulse and measure their heart rate. A good heart rate for exercise and conditioning is 60 to 80% of their predicted maximum heart rate, and the predicted maximum heart rate can be determined by taking 220 and subtracting the patient's age. Also favor the use of heat and range of motion, specifically in the shower. I ask them to go through the range of motion of all their joints. Other things that can be helpful: massages, rubs, or liniments. Manipulative therapy, such as massage and chiropractic, can offer benefit. Tender point injections can help the patients. Interestingly, the data would suggest just putting a needle into the area can help, and just maybe injecting some saline. I would inject a little bit of numbing medicine and a little bit of a corticosteroid into the areas of tenderness. And then peripheral analgesics such as acetaminophen and nonsteroidals, anti-inflammatory drugs, are used, although maybe not with that much benefit. Sleep is very important, and the patients need to allow adequate time for sleep. I've had patients come in getting as little as 4 hours of sleep per night and finding they were not doing well, and no wonder. I think that a lot of times those of us that were in training, at least back when I was in training, we would have to take all night call and sometimes would go 36 hours without sleep. And generally at the end of that time, one was feeling an achiness and an overwhelming fatigue. And I think that's probably not unlike what occurs in fibromyalgia. So the lack of sleep is important. There should be a regular sleep interval, and what I mean by that is to go to bed at the same time each night and to get up at the same time each morning. And I encourage people to set an alarm and get up at that time no matter what. Again, one of the problems that I've seen with some people with fibromyalgia is that they go to bed, can't sleep, so they try to catch up their sleep in the morning, and it just sort of prolongs the problem. One's really trying to train their body to sleep at the right time. One needs a quiet sleep environment. There should be no caffeine in the evening, and the bed should be reserved for sleep. There shouldn't be a TV in the bedroom to watch. Sleep disorders that can keep one awake need to be treated, including restless legs, nocturnal leg cramps, although leg cramps is one of the mysteries of medicine of how we effectively treat it. And if they have sleep apnea, that should be treated. Now, the medicines that we use, classically, we used antidepressants such as amitriptyline, etc. Those can be used also to help sleep. Trazodone is used to help sleep, and things like diphenhydramine, Benadryl, etc. can be helpful for sleep. Currently, anxiolytics are not recommended. Now, in order to treat this, we are targeting the pain pathways, and we're going to talk a little bit about how the different medicines can affect the pain pathways. The tricyclic antidepressants were the first medicines that were used for fibromyalgia and shown to be helpful. As you recall, when we talked about the windup that occurs in the dorsal horn of the spinal cord and how that can be downregulated by serotonin, 5-HT, and norepinephrine. Well, the tricyclic antidepressants decrease the reuptake of these from the synapse in the between the nerves, and by decreasing the reuptake of that increases the amount of serotonin and norepinephrine in the synapse and can actually downregulate the pain sensation going up to the brain. And so these medicines have been found to be helpful. Amitriptyline classically, and doxepin. Cyclobenzaprine is actually a tricyclic but is sold as a muscle relaxant. Now, there's a newer class of medicines called the selective serotonin reuptake inhibitors, and these things include things like fluoxetine or Prozac, sertraline, citalopram. When these came out, it was a big deal. They really did improve the treatment of depression, in that they were helpful and worked and had fewer side effects. However, they're not as effective in the treatment of fibromyalgia. The serotonin norepinephrine dual reuptake inhibitors, or SNRIs, again, these medicines increase the amount of serotonin norepinephrine. They downregulate the windup that occurs in the synapse, and they have a lot of the benefits of the tricyclic depressants without quite the side effects. And I say without quite the side effects, they do still have side effects. And at least two of these medicines are actually approved by the FDA for the treatment of fibromyalgia. Milnacipran or Savella and duloxetine or Cymbalta have been approved for treatment in fibromyalgia. Other targets that have tried mu-opioid, this would include narcotics. However, narcotics are actually found to be counterproductive in fibromyalgia and are not favored. The medicine tramadol or Ultram has some intriguing effects. It can affect the mu-opioid receptor. It can affect serotonin and norepinephrine, and thus one would think that it could be a special drug in the treatment of fibromyalgia. Problems with it, however, is that sometimes there can be seizures associated with it, especially when used with tricyclic antidepressants such as amitriptyline, and is concern about abuse with chronic use. So whereas there was a lot of interest in that in the past, some of that is waning. Anti-seizure medicines such as gabapentin and pregabalin again can affect the cation channels in GABA and again downregulate the transmission up the spinal thalamic tract. Pregabalin or Lyrica is also approved in the treatment of fibromyalgia by the FDA, and thus, at least right now, there are only 3 medicines that have been approved. These include the duloxetine, the milnacipran, and the pregabalin. Benzodiazepines may affect GABA, but again, we're shying away from the use of those currently. And then tizanidine, which is marketed as a muscle relaxant, is an alpha-2 antagonist, and it may be a benefit. NMD antagonists have been used. Ketamine is one of these, and this is a general anesthetic. It can be associated with a lot of psychic disturbances. There is some uncontrolled studies showing the benefit of ketamine IV in the treatment of chronic pain. However, they are uncontrolled. There's not any data really to support its use. Dextromethorphan or cough syrup can affect NMDA. And it's interesting, this has been proposed as a treatment for many years. I looked at clinicaltrials.gov recently, and I see that there's currently some current studies in the use of dextromethorphan to treat fibromyalgia. Other things that have been looked at: 5-HT3 antagonists, which includes things like topisterin or ondansetron, which is marketed as Zofran for nausea. There is some data to suggest some benefit with these in some patients. Again, though, this has not really taken hold, and I've not seen that used as a treatment. Substance P, this has been looked at, and again, there's a anti-nausea medicine used for chemotherapy. However, there is not currently a treatment using that for fibromyalgia. Just as sort of to tie this up with respect to single drug therapy, there was a study performed by Dr. S.C. Kim that showed that many patients that started these medicines did not continue long on their medicine for fibromyalgia. Now, with respect to refractory fibromyalgia, combination therapy can sometimes be a benefit, and this includes the use of low-dose selective serotonin reuptake inhibitors like fluoxetine in combination with a tricyclic antidepressant at nighttime, or possibly a low-dose serotonin norepinephrine reuptake inhibitor such as duloxetine or milnacipran associated with an anticonvulsant at night. Other things that may have been a benefit, I think there is probably a role of integrative care in the treatment of this, and what I mean by that is a team of people such as a psychologist, physical therapist or trainer, perhaps manipulative therapy such as chiropractic or massage therapy can be a benefit. What I don't mean by integrative therapy is I don't mean programs that include high-dose IV vitamins or treat everything as chronic Lyme disease. Lastly, it is important to evaluate the patient for fibro-plus, and I think that's probably the role of the rheumatologist. We can do the physical exam. We can see if it is just fibromyalgia or if there's another process going on, such as rheumatoid arthritis or something, which is contributing to the pain and needs to be dealt with. Now, what follow-up is required for these patients? Generally, follow-up is determined by the medicines one is using in order to monitor those. I have found in the past, though, that it is helpful to make sure the patients do have follow-up appointments every 3 to 6 months, as sometimes their use will be more greater than that, and so it's nice to give them sort of an endpoint of when to come back. It should be noted that many rheumatologists are now not following fibromyalgia patients with isolated fibromyalgia. I think one of the problems is that this can oftentimes swamp the practice, and then there's an access problem in rheumatology in that there's not enough rheumatologists to go around, and so rheumatologists are sending these patients back to their primary physicians for management, with the caveat that they're certainly happy to see them and reevaluate to make sure there's not another process going on. Again, I thank you very much for listening to my discussion. I hope this is helpful to you. Certainly, I hope it's helpful in trying to understand this condition. This is a very frustrating condition, I think, for both patients and physicians. It's difficult for the patients to live with, and it's difficult for the physicians, as our tools do not seem great or adequate in this condition, and the patients don't reward physicians by getting better. I think a lot of us as physicians like to help our patients and like to see them better, and when they don't, we are frustrated. Thank you, and I look forward to further talks in the future. Bye. This is a painting called The Broken Column by Frida Kahlo. Frida Kahlo was a Mexican artist who lived from 1907 to 1954 and died at the age of 47. She had a severe bus accident as a teenager at the age of 18, and following that had over 30 operations in her lifetime. Dr. Manuel Martinez Lavin, in a concise communication to the journal Arthritis and Rheumatism, proposed that she suffered from post-traumatic fibromyalgia. He also stated, "What appears certain is that Frida's self-portraits convey widespread pain and anguish with the emotional overtones that fibromyalgia patients frequently use to describe their illness."
So that concludes this talk. I thank you very much, and there'll be further to follow.